Hello everyone. At the outset, I would like to thank the ISCCM Hyderabad chapter for the organization of this National Nurses Conference and giving us as an opportunity for this talk. So today my topic is about the blood and blood product transfusion in ICU. So coming to the outline, we will first know about the blood and its products, then the indications for transfusions, the triggers, the dose and the storage, the transfusion reactions, and the master transfusion protocol. So whole blood may be divided into four components. That is the red cells, the white blood cells, the plasma, and the platelets. Plasma is further divided into fresh frozen plasma and the fractionated products, which include the factor 7A, factor 8, and factor 9. These three are now available as recombinant products also. And the fresh frozen plasma, which can be divided into cryoprecipitate and the cryoprecipitate plasma. So the common indications for transfusions for the PRBC include anemia and the hemorrhagic shock as a part of massive transfusion protocol in a polytrauma patient, as intra and a post-op bleed, as in postpartum hemorrhage, or any upper GI and lower GI bleed in the ICU. So the indication for transfusion of platelets include severe thrombocytopenia less than 10,000, or any platelet count causing severe bleed, and in DIC, and along with the blood transfusion in MTP protocol. And in patients using antiplatelets, that is GP2B and 3A inhibitors who require emergency surgery. Indications for transfusion of granulocytes, that is the white blood cells, include profound neutropenia and neutropenic sepsis. Whole blood nowadays is very rarely used because of the complications causing fluid overload and any anaphylactic and immunogenic reactions because of the leukocytes in that. And now commonly used red blood cells concentrates are used, which are commonly used in hemorrhage and anemia in shock. And leukodepleted blood cells are used in patients who have neutropenic patients and who have a febrile reaction to the transfusion, and in hematopoietic stem cell transplant patients and bone marrow transplant patients. Platelet concentrates are used in patients with severe thrombocytopenia due to marrow hyperplasia or platelet dysfunction. Fresh frozen plasma again is used in patients who have a single or a multiple coagulation pattern abnormalities, depending on the INR which we test. And cryoprecipitates are commonly used in patients who have hypofibrinogenemia. The fibrinogen levels are less than 100 or less than 80 in a polytrauma patient. These cryoprecipitates are commonly used. So trigger for PRBC transfusion ICU in a normal healthy adult, 7 gram per deciliter is target. Anything less than 7 grams we need to transfuse to increase the oxygen carrying capacity of the blood. As we know that hemoglobin reversibly binds to oxygen and it transports the oxygen in the blood. And in patients who have a comorbid conditions like a CAD, coronary artery disease, or in pulmonary disorders, the target is slightly higher, around 8 grams per deciliter. In a neurotrauma patient, and in a polytrauma patient also, the target is slightly higher with 8 to 10 grams per deciliter. In post-op patients also, the target is around 8 grams per deciliter. So coming to the individual components, whole blood, a packet contains approximately 350 ml of blood, and if you aspirate a blood and aspirate a sample and send for analysis, you get a hemoglobin of around 12 gram per deciliter and hematocrit of 35 to 45%. The transfusion is usually started within 30 minutes of removing from the refrigerator and completed in 4 hours of starting. It is usually stored at 2 to 6 degrees Celsius. Packed RBCs, again, the plasma is removed from the whole blood, and packed RBCs are processed to volume of around 150 to 200 ml of red cells. A sample from them will contain higher HB, that is about 20 gram per deciliter, whereas hematocrit of 55 to 75%. Each unit is equal to 1 donation or 1 pack, and the storage is same at 2 degrees Celsius. Leukodepleted RBCs are devoid of any WBCs, and they have less reaction, less immunization reaction, or less anaphylactic reaction, and it also reduces the risk of infection transmission, that is by the cytomegalovirus. Storage is same at 2 degrees Celsius. So prolonged storage of RBCs should be avoided. Usually we store the RBCs for 35 to 42 days at 4 degrees Celsius. As the storage life of RBCs increases, the potassium in the bag may increase because of the cell lysis, and the plasma ammonia levels may increase. It may become acidotic, and the PCO2 levels may increase in the blood, in the stored blood. And there may also be a change in the shape of RBCs. So all these contributes to reduced oxygen delivery and hypocalcemia and hyperkalemia when given in large amounts. So in patients who require massive transfusions, uh, we try to give as long as possible, as far as possible, we try to give fresh blood instead of a stored blood. So one PRVC may increase your hematocrit by around 3%, which approximates to about 1 gram per deciliter of hemoglobin increase. This may take up to 24 hours to equilibrate the intravascular volume. And coming to the platelet transfusions, we have two components in the platelets. One is the RDP and one is the SDP. RDP stands for random donor platelets. We try to take whole blood from random donors and try to process in the plasma. Each bag of RDP contains at least 50 to 60 ml of volume, and which contributes to 55,000 of platelets. It is stored at room temperature of 22 to 24 degrees Celsius with and it should be infused over a period of 30 minutes with a transfusion cell without a filter, because the filter may damage the platelets. Dose is approximately 1 unit of RDP per 10 kg of body weight in adults. So for an adult of 60 to 70 kgs, 4 to 6 units of RDP is transfused to increase the platelets. And SDP is prepared from whole blood by platelet apheresis, volume of approximately 150 to 300 ml. It contains higher amount of platelets, 1.5 to 5 lakhs. Now, one pack is one therapeutic dose, and then storage is same at room temperature of 22 to 24 degrees Celsius. Indication of transfusion by platelets is recommended by the Association of Advancement in Blood and Biometrics, that they recommend to give platelets in patients undergoing chemotherapy or hematopoietic stem cell transplant with a platelet count of less than 10,000. Mind you, any patient with thrombocytopenia with any bleeding tendency need to be transfused platelets, or if any invasive procedure we're planning for a patient with thrombocytopenia, the target is at least 50,000 for a lumbar puncture or central line. And in neurological procedures or neurosurgery patients, we need to target the platelets of approximately 1 lakh and above, as recommended by the American Society of Anesthesiologists. So here the therapeutic effect in a 70 kg male with normal size of spleen, each unit of RDP may increase the platelets by 7,000. Then coming to the plasma, fresh frozen plasma, usually the indication is to maintain the INR. Elective surgeries or emergency surgeries, the INR should be maintained around less than or equal to 1.5. No hard and fast rule, but patients who require a lot of transfusions along with the blood, we also transfuse FFPs in 1:1 ratio. So each pack of cells, as I discussed, it contains 200 to 300 ml of plasma, which is rapidly frozen to minus 25 degrees Celsius or colder. And when we order the release of FFP, they thought that FFP from minus 25 degrees to 30 to 37 degrees, they liquefy it and they give it at 2 to 6 degrees Celsius. And this should be infused within 6 hours of thawing. The dose is usually 50 ml per kg of body weight. Cryoprecipitate again is prepared from FFP by collecting the precipitate formed during controlled thawing at 4 degrees Celsius. It contains factor 8 and fibrinogen levels. Factor 8 usually in the range of 80 to 100 international units per pack, and fibrinogen in the range of 150 to 300 milligram per pack. So one pack is equal to approximately 6 or more single donor units, and a pool of 10 single donor units is the dose. Time limit for transfusion, as we discussed, whole blood should be started transfusion within 30 minutes of removing from the refrigerator and should be completed within 4 hours or less. And platelet concentrate should be transfused immediately, and within 20 minutes, the transfusion should be completed. FFP and cryoprecipitate also should be transfused as soon as possible, and within 20 minutes, the procedure should be completed. Coming to the transfusion reactions, which are most important part, we categorize them into category 1, category 2, and category 3. Category 1 include mild reactions because of hypersensitivity and anaphylactic reactions because they may lead to pruritus, itching, or urticaria and rash. Moderate to severe reactions, that is category 2, may include anxiety, pruritus, palpitations, mild dyspnea, and headache. The signs may include urticaria, rigors, fever, restlessness, tachycardia. Causes may include because of, again, anaphylactic reactions or febrile non-hemolytic reactions because of antibodies to white blood cells, and possibility of contamination by bacteria also there. Then life-threatening reactions include category 3, that is symptoms may include anxiety, chest pain, loin pain, and pain near the infusion site, and respiratory distress, SOB, and falling BP of more than 20% from the baseline in systolic BP, and the tachycardia, that is rise in heart rate of more than 20% from the baseline in the heart rate. Hemoglobinuria, there is appearance of blood in the urine because of hemolysis, and unexplained bleeding may occur because of the DIC in late stages. Possible causes include acute intravascular hemolysis, the battle contamination, septic shock, and also because of transfusion-related acute lung injury. So category 1, the treatment is slow transfusion, and symptomatically treat with antihistamines, IM or IV. And if there is no improvement within 30 minutes, then progress to the category 2 treatment. That is, stop the transfusion, return the blood unit along with the infusion set and a freshly collected urine sample and a new blood sample, among which the one sample should be clotted and one should be anticoagulated from the vein opposite to the site of infusion. Then you treat symptomatically the patients with antihistamines, our hydrocodone and corticosteroids and antipyretics, and the bronchodilators. Urine should be monitored for the next 24 to 48 hours for the possibility of hemoglobinuria or hemolysis. Restart the transfusion if the patient has improved within 15 minutes. If not, progress to category 3 treatment, that is infuse saline at a 20-30 ml per kg rate, and maintain the airway, and infuse adrenaline as 0.01 mg per kg of body weight by slow IM or IV injection in the dose of 1:1000 solution. Reassess the patient if there is any hypotension. Reactions may also be classified according to acute and delayed. Acute reactions may include anaphylactic reactions, febrile non-hemolytic reactions, acute hemolytic transfusion reactions, transfusion associated with circulatory overload, and transfusion-related acute lung injury, that is TRALI, and TRIM, that is transfusion-related immunomodulation. Delayed reactions may include delayed hemolytic transfusion reactions and transfusion-associated graft versus host disease. So we'll come to this one by one. The infectious complications may also include the transmission of HIV, the transmission of hepatitis B and C, and the Epstein-Barr virus, the cytomegalovirus, human parvovirus, the human herpes virus, transmission of malaria, syphilis, and transmission of other bacteria. So coming to TRALI, the transfusion-related acute lung injury, it may confuse us with similar to ARDS. The symptoms may be similar to ARDS, that is, patient may have tachycardia, tachypnea, hypoxia, desaturation, fever, and exclamation bilateral infiltrate, which is non-specific. And the symptoms may begin within 30 minutes to 6 hours after transfusion. TRALI usually occurs when the donor platelets, donor plasma contains antibodies against the patient's HLA or leukocyte-specific antigen. Treatment is mainly supportive. Patients may recover. Usually 80% to 90% patients may recover, but they may require support with oxygen or NIV, or sometimes in severe cases may require ventilator support also. Coming to transfusion-associated circulatory overload or cardiac overload, the incidence is 1 to 8% of patients who are transfused with blood, more commonly seen in patients receiving multiple blood products. And also at-risk patients includes older age, congestive heart failure patients, chronic pulmonary patients, and even the chronic renal failure patients requiring with hemorrhagic shock requiring multiple blood products. Signs may include exacerbation of SOB, the development of respiratory distress, increase in proBNP levels, and increased CVP levels, and the obvious evidence of positive fluid balance. and the radiographic evidence of pulmonary edema. Pathophysiology may include the development of pulmonary edema and increase in capillary hydrostatic pressure causing a reduced lung compliance. Diagnosis is usually clinical because it may confuse us with laterally again, and symptoms may include dyspnea, non-productive cough, tachycardia, cardiomegaly, and the bilateral infiltration test X-ray. Treatment is supportive, discontinue the transfusion, give support with oxygen and diuretics. Mortality again is ranged from 1 to 8%. Coming to transfusion-associated graft versus host disease, this is also an autoimmune-mediated reaction because of the donor T lymphocytes, they proliferate and they attack against the patient tissue. More commonly seen in immunocompromised individuals, it may be fatal and devastating. Onset is usually seen delayed after 2 to 4 weeks after allogeneic transfusion. Signs symptoms may include a fever or the development of transaminitis with LFT abnormalities, profuse watery diarrhea, and the development of erythematous skin rash and progressive marrow failure. Treatment again is supportive and supporting the multi-organ failures. Then there is no evidence that warming the blood is beneficial to the patient when the infusion rate is very slow. If patient requires very high transfusion rate, that is in adults more than 50 ml per kg per hour transfusion is required, or in children more than 15 ml per kg per hour is required, then we need to warm the blood. Otherwise, there may be a risk of cardiac arrest. Then coming to the massive blood transfusion, the definition is that it is defined as the replacement of one entire blood volume within 24 hours, or the transfusion of more than 10 units of packed RBCs in 24 hours, or the transfusion of more than 4 units of PRBCs in 1 hour when ongoing need is foreseeable, and the replacement of 50% of total blood volume within 3 hours. There were many randomized controlled trials, one of which is the proper trial, which mentioned that the transfusion of in a massive transfusion protocol, a transfusion of plasma, platelets, and RBCs should be done in 1:1:1 ratio compared to 1:1:2 ratio. So they showed that in the group 1, there is 1:1:1 ratio. Predominant cause of death was significantly decreased within 24 hours. That is, there was less blood loss in the patients when we give 1:1:1 ratio. And also more patients in the first group achieved hemostasis early than in the second group. Hence, it is recommended to give the ratio of plasma to platelets and the RBCs in the ratio of 1:1:1 compared 1:1:1 compared to 1:1:2 in a massive transfusion protocol. And once the patient comes with a massive transfusion requirement, your doctor notifies you. Then this should be notified to the blood bank, and either if it is very urgent without any blood matching, O negative blood is a universal donor which can be given. And for the FFPs, we need not match AB compatibility is required, but RH compatibility is not required for the FFPs. And notify the doctors, notify the blood bank in case of any transfusion reactions. Thank you.